Good afternoon, everybody. Here we are on our weekly webinar from EMMAC. This week, we're very excited about the webinar that we are about to present. It's a clinical update on the AIDS 2020 conference. We know that this was the first time this kind of conference was done virtually, and though many people attended, we thought that it would be a good idea to provide the community with a comprehensive summary of the highlights related to AIDS 2020 and the new data and the new information that came out of the conference. And today, as the presenter, we have Dr. David Hardy. Dr. David Hardy is an adjunct professor of medicine in the Division of Infectious Diseases at Johns Hopkins University School of Medicine. He previously served as director of the Division of Infectious Diseases at Cedars-Sinai Medical Center and professor of medicine at the David Geffen School of Medicine at UCLA, and as a senior director of evidence-based practices, ACTG clinical research site, CRS leader, Max co-investigator and HIV primary care provider at Whitman Walker Health in Washington, D.C. He received also his medical degree from Baylor College of Medicine, Houston, Texas, and completed his residency in internal medicine at Harvard UCLA Medical Center in Torrance, California. Dr. Hardy completed a clinical fellowship in infectious diseases, immunology, and clinical research at the School of Medicine, and later a postdoctoral fellowship in molecular vector biology at the David Geffen School of Medicine at UCLA. He is a board certified internal medicine and infectious diseases, as well as credentialed, that's a complicated word, HIV specialist. Dr. Hardy has been treating HIV patients since 1982. He is involved in many clinical studies, and I'm very lucky to call him also a friend. He has been part of our community since the very beginning, and it's one of those physicians that have made a big difference in the research that is done, and actually, you know, one of the people that we have to be grateful for because of the new medications that came out to the market because of brilliant people like Dr. Hardy. So now I will let you hear his presentation, and then we'll have some time for discussion and Q&A. David?
Thank you very much, Moises. That was a very unnecessary but very comprehensive introduction. Thank you for reminding me my entire life. Is my screen being projected yet?
Yeah, the desktop.
Mm-hmm. Desktop. Oh goodness. Okay, let me pull up the slides then. Oh God, make sure I can do this. No. All right, audience view. Why can't I find my? I thought I had to pull those up. Bear with me just a second, if you will.
It's all right.
I need to figure out how I can get my slides up again. Wait a minute, let me put it back up. Ooh. All right, here it is. There.
Yeah.
Woo! A little more technology. There we go. It's not, is that projecting now?
Yes. Yes.
Great.
Perfect.
Sorry for the delay there. I'm going to stop my webcam just for right now so you can see the slides completely. So as Moises said, what I hope to do over the next hour or so is to give you a sort of a high level view of what happened at the International AIDS Conference 2020, the first all virtual HIV AIDS conference on the international sort. And hopefully you'll be able to take away something new and different than before. Here are my disclosures. And I set up some educational objectives, which really aren't too much different than what you might expect about looking at advances in antiretroviral therapy, as well as those for treatment and prevention of HIV infection. But this conference was in fact different because, of course, it was occurring in the midst of a global pandemic of COVID-19. So one full day of the conference was dedicated to looking at the interaction between HIV and COVID-19. So I'll have a few slides about that as well. The overview of my presentation is shown here. I'm going to give you some highlights from current antiretroviral therapy, focus on some of the metabolic effects of antiretroviral therapy, including weight gain and others. Look at the new developments in ART and pregnancy, which I think are very important, as well as HIV prevention. Big news coming out of the conference about that. Look at a couple of investigational HIV treatments in the pipeline, a little bit about HIV cure, and then I'll wrap up with COVID-19 and HIV interaction and leave some time for the panel as well as questions and answers. So let me start off with about current ART. This conference had over 5,000 abstracts, so I'm not going to be able to really give you all of them, but I'll give you some of the highlights that I thought were particularly important. Coming from San Francisco, from the University of California, San Francisco, UCSF, there was a report of a acute HIV cohort, meaning that patients were diagnosed with HIV within 100 days of the estimated infection and started on therapy right away. This was a community-based effort in which patients were referred from the Department of Public Health clinics, CBOs, private health clinics, as well as hospitals and HIV testing spots for about 6 years between 2015 and 2019. Again, acute HIV was defined as that being diagnosed within 100 days or less of date of infection. And all patients were started on immediate antiretroviral therapy with dolutegravir plus either Truvada or Descovy, and followed for at least 24 weeks, at least 6 months. Of note, they noticed that over a quarter of the patients had false negative or indeterminate testing for HIV infection, which is really a documentation that they actually are finding acutely infected patients. And the table to the right really shows the interval from diagnosis to ART initiation, with a large number occurring, almost 20% there, between the first 2 weeks of suspected infection, where false negatives would be expected to occur. They also found that there was overlapping PrEP use at the time of diagnosis in about 10% of the patients, meaning that they had been started on PrEP erroneously, or at least the fact that they were in the midst of seroconversion at the time the PrEP was started, meaning their HIV infection was missed in about 55% of those who were started on PrEP. Further, the proportion of patients that became undetectable by week 24, less than 50 copies of viral load, was 82%, which is actually very good for an early time point like 24 weeks. The persistence in the study, which in this case is very important in terms of adherence to both study medication as well as study care, was 90% at 6 months and great 73% at greater than 2 years, which is actually, I think, very, very good. So the results of this study really showed that approaches to identify and treat acute HIV infection can help lead to virologic suppression of a very high rate and very good retention levels. Just looking at some of the demographics, there were 60 patients in this study. They were all MSM. Average median age was 30. The racial ethnic background was 33% white, 20% Black or African American, 30% Hispanic, and 17% Asian. So actually pretty diverse in the city of San Francisco. And as you can see there was a pretty wide range of when people were being diagnosed, although almost half were diagnosed after a month. Similarly, coming from San Francisco also, I think was a very interesting rapid start program that was nurse-led. Again, a large community-based sexual health wellness organization offering immediate ART at the time of diagnosis. They reported on 115 patients that received immediate ART over the 3-year period of 2018 to 2020. On average, these were 31-year-old males, 48% Latinx, 22% white, and 10% African American Black. 60% had stable housing, 14 unstable, and the breakdown in terms of sexual orientation or risk factor was 70% MSM, 13% IDU, and 16% heterosexual orientation. So acute HIV infection was diagnosed in almost 20%, and CD4 cell counts were just below 500. 99% of people started on antiretroviral therapy, 78% on the same day as diagnosis, and 92% within 1 week. So this was very successful in what we would certainly classify as rapid start. The median follow-up was about 1.25 years, and at follow-up, 91% were undetectable, less than 200. The median time to viral load suppression was just over a month at 34 days. So obviously they were using integrase inhibitors as the primary therapy here. Viral rebound occurred in only 6 out of the 115 patients, and 3 re-achieved suppression. So again, this I think is really showing that the results suggest that an HIV testing site can initiate rapid same-day ART, accomplish care linkage in a fashion that is in fact durable and achieves high viral load suppression. And you can see in the table, in the figure to the right, the fact that there was in fact good suppression and also good retention and care. So I'm going to move on now to a study that may be of interest to many people in the call, because I know this is a group of individuals who have been living with HIV for some time. And this was a pooled analysis of 4 different randomized international trials, including bictegravir, TAF FTC, or Biktarvy. And in these trials, what they did is they basically picked out the individuals that were 65 years of older to come up with a large enough cohort of people to really look at the response rate to antiretroviral therapy, either switch or initiation. Sorry, or either not switch, but not initiation, but sorry, switch to Biktarvy, or maintaining their current regimen of many different kinds there, protease inhibitors and also dolutegravir-based regimens, and see how people over 65 did. I think the first good news here was that 129 out of the 100. Well, let me back up 1 second. You can see these trials were fairly large trials that enrolled somewhere between 400 to 500 patients. And so the proportion of patients over 65 was rather small, as you can see there, except for the one trial called the 449 trial, which was a trial that actually looked at older persons to begin with. But by taking smaller numbers from other trials, they were actually able to put together a group of 140 persons over 65 with HIV infection. The good news is that at 1 month, at 1 year follow-up, 92% of these individuals maintained their virologic suppression, which is really great, really good to hear. And only 8% had no virologic data. So they are not saying that there was in fact very many failures. Only 5 patients out of the 140 discontinued because of adverse events or death, and they all at that time were undetectable. One of the things, of course, that is very concerning, and as persons live longer with HIV or start HIV at a later stage in life, is the effect that comorbidities, for one thing, that increase in all of us as we age, but also the fact that adverse events may be becoming more common because of poor tolerance of medications. But this study really did not show that. The good news was that only 2 or 1.4% of patients had a grade 2 or 4 treatment-related adverse event. None had a grade 3 or 4 treatment-related adverse event. There was only 14 grade 3 or 4 laboratory abnormalities. There were no treatment serious adverse events, and the number of adverse events leading to medication discontinuation was only 4 out of a total of 140, or less than 3%. So I think this was actually very, very important. Only one death, and it was not considered to be related to study treatments. Because weight and metabolic changes, of course, are very important in any therapies we use in HIV infection today. The median weight gain was 1 kilogram after a year, which is about what we would expect with any kind of normal aging. The renal function or changes in what the renal function looked like, called the eGFR, went down, but just a small amount at just less than 3 mils per minute. It's probably not significant. And only 4% of patients started lipid-lowering medications to decrease their cholesterol. So again, this is, I think, really showing some pretty clean and effective therapy for persons over 65, a special group of HIV-positive individuals. Moving on now to kind of looking at how potent and how durable our antiretroviral medications are. A study called the 40-30 study was one in which patients who were on dolutegravir with either Truvada or Descovy were then switched over to Biktarvy. Patients who were already undetectable on the dolutegravir regimen, the switch to Biktarvy, TAF, FTC, or Biktarvy was actually very successful. In the overall study, what was seen was that there was no significant difference in terms of the number of patients that had virologic breakthrough. It actually was very small. Another way to look at how durable and how potent the viral load suppression is to look at how frequent viral blips, meaning a viral load level less than 200 but greater than 50, sort of in that kind of questionable zone of greater than 50 but less than 200. They found that this was a very infrequent event on these two integrase-based regimens, 0.5% for the Biktarvy, less than that, 0.4%, but very similar for the dolutegravir regimens. And so I think the important thing here was to show that the patient, this study was sort of interesting also in that it allowed patients to come into the study who either had a history of or were found to have a nucleoside resistant mutation in their virus. So they were really trying to see whether or not switching off of a regimen that was working onto Biktarvy would work even with an M184V or a TAM or a K65R mutation. And the good news is that there was no patient with blips qualified for resistance analysis, which is telling us that blips in this case was not predicting virologic breakthrough and resistance. And I think that is something that is really worth understanding and feeling good about. There was really no difference in those patients that stayed on dolutegravir or those who switched to Biktarvy. The number of blips was very, very similar. And I think the important thing here is that this really, I think, indicates the potency and the durability of our two most current integrase-based regimens. Let me move on now to some of the metabolic effects of antiretroviral therapy and weight gain. I'll just say to begin with, as that last slide showed, we have really good antiretroviral medications that we can use either as first-line therapy to start or to switch. And most of these, of course, are integrase-based therapies. And as that last slide showed, the difference between Biktarvy or dolutegravir-based regimen is really difficult to find because they're both very, very potent and both very, very well tolerated. But what is going to differentiate medications for the future? And I think one of the things we need to look at, of course, are the metabolic effects of the antiretroviral regimens, and particularly at weight gain, because this is something that has come up as a new adverse event, or at least an effect that can have adverse events, especially down the road. So first, to kind of give an idea about this, how much weight or how much change in body mass index, which is a factor of weight and and height, do people with HIV who are starting antiretroviral therapy gain? So the Kaiser Permanente electronic medical database has been very helpful in trying to look at changes that occur in HIV positive persons versus those that occur in HIV negative persons. It's a very large database that's including almost 140,000 individuals from the different Kaiser hospitals around the country, West Coast and East Coast. But what they saw in this, what they did in this study was to look at the change in body mass index, meaning number of kilograms per meter squared of height, weight compared to height, between 2006 and 2016, that 10-year period of time in which patients were starting antiretroviral therapy. And the importance about that time period is that it started just before any integrase inhibitor was licensed, before raltegravir was licensed in 2007. So patients were oftentimes started on, of course, protease inhibitors and NNRTIs. But it went through 2016, where integrase inhibitors really became the most commonly used regimen. So in a match cohort of looking at HIV positive starting therapy versus HIV negatives, what was seen here in the table to the right there is that the change in body mass index by status really showed that in persons starting antiretroviral therapy, there was a significant amount of increase in weight per height in the HIV positives that was significantly different than those persons who are HIV negative and were just aging over that 12-year period of time. So this kind of gives us an idea about the fact that when HIV positive persons start antiretroviral medication, number one, their weight is lower than HIV negative people, and it actually increases more dramatically, and it's basically at the end of 12 years there in the same ballpark because the 95% confidence intervals are now overlapping. So this is something that is occurring not with any particular antiretroviral regimen, but with just in general with persons starting ART. They also broke down individuals who started off with a normal or underweight, those who were overweight, and those who started off being obese. And as you can see, those who are normal or underweight were not really different between HIV positive and HIV negatives. And over the time, the HIV positive persons did gain more weight significantly than HIV negative persons did. For the persons who were overweight to begin with, again, they were almost exactly the same at the beginning of this study. But as time went on, the HIV positives did gain more weight, significantly more weight over the 12 years compared to HIV negative individuals. And then finally, the interesting thing about obese patients, there was really not a big significant difference because they were overlapping the entire time of the study. But what's interesting to note here is that while HIV positive persons were in fact gaining weight during that over this 12-year period of time, but not a whole lot, the HIV negative persons were really only lost just a little bit. So this is in fact, I think, an important thing to look at the fact that we know people who start antiretroviral therapy are going to gain weight no matter probably whatever it is they take. So let's go forward to see if we can kind of differentiate between different regimens and different kinds of weight gain, because we know that almost all people are going to gain weight when they start therapy because they're shutting down a very, very strong and very, very potent viral infection with the medication that has oftentimes been causing them to lose weight, whether they really understood it or not. So the ADVANCE study, a very important randomized controlled clinical trial coming to us from South Africa and still ongoing, I should note, studied a population of patients that we oftentimes do not see a lot of data from in the United States. This study was 60% African American, 60% women, 99% Black African. And I think that's something that's really very important. Of note, the median weight was 66 kilograms to begin with, but also of note, the weight in women was actually higher at around 69 kilograms versus the weight in men, which was at 65 kilograms average. And this was done in a resource limited setting in Johannesburg, South Africa. The trial was one that basically started patients on medication, and there were over 1,000 in this study on 3 different regimens, either a tripla, the lower blue there, dolutegravir plus Truvada, or dolutegravir plus a TAF regimen, Descovy. And so the first thing to look at was how well did each one of these work against the virus. And the good news is that there was really no statistically significant difference at either the first year of viral suppression or, as this study reported now at this conference, at 2 years of follow-up. There was all 3 regimens were considered to be non-inferior to each other, indicating that they all did in fact have a good suppression of virus. There was, however, a difference in those patients that had virologic failure and had consequences of resistance. 0 resistance for those 12 patients that failed in the dolutegravir TAF FTC arm. 13% who failed had some NRTI mutations, but not integrase mutations. in the dolutegravir plus Truvada arm. And of course, as you might expect, those 21 patients that had a failure in the triple arm, 62%, almost 2/3 had new mutations, but that's what we expect with the efavirenz anyway. The adverse events were actually very small, really not significantly different between the three arms. But the thing that's really come out interesting about the advanced study is the weight gain in both men and women, but particularly in these African women. As we see there, some of these patients have actually been in the study for as long as 3 years, 144 weeks. And those weight changes have been continuing on. As you can see, there is a big difference in terms of how much weight both the men and the women gained and at the first year, the second year, and the third year. For the men, the weight gain was the most dramatic in the first 48 weeks, and then it seemed to kind of level off in the second year of study between 48 and 96 weeks. But then after 96 weeks, you can still see some weight gain occurring there in the men, but particularly and most dramatically with the dolutegravir plus TAF regimen. Let's look at the women just for a second. When we see what happened in the women, we actually see an even bigger difference between those patients started on tripla, those started on dolutegravir plus Truvada, or those started on dolutegravir plus the TAF regimen, Descovy. And at the end of 3 years, those patients who had made it to that far in the study, although the study has not gotten completely to that point yet, on average, the women gained 12.3 kilograms, or over 25 pounds. Of note, this was something that had to be kind of looked at in terms of the cultural context of where it was being done, in that when questioned about the changes in weight, the women in the study did not seem to be bothered by the increased weight. Important to know. This study, even though it was done in a resource-limited setting, actually did some very high-tech sort of evaluation, looking at whole body DEXA scans, which can demonstrate what kind of body weight, whether it's lean muscle weight in the limbs or in the trunk, or whether it's fat weight gain. And what you can see is that in the patients who were on the dolutegravir plus TAF arm, there was primarily fat all the way across the board, both women and men. And although there was some muscle mass gain in the women and men with dolutegravir, there was very little muscle gain with efavirenz, which I think really re-emphasizes some of the things we knew previously about the way that efavirenz does in fact change body metabolism. But this is, I think, telling us something very important. The weight gain that was occurring was not healthy, lean body mass, not muscle. It was in fact primarily fat, which isn't always very healthy. So the conclusions from this very important and ongoing study is that all three regimens worked well in suppressing the virus. There were more mutations with the efavirenz, the Truvada, with the a triple arm, and that notably the dolutegravir plus FTAF arm had greater increases in body weight that continued past 2 years of follow-up, greatest in the women more than the men, greater in trunk fat. And interestingly, in the women, there was a higher risk of what's called the metabolic syndrome, because weight gain by itself may not actually be such a difficult or problematic thing, but what we know is associated with weight gain are two things. One is the metabolic syndrome, which is a combination of things that actually show that the person is becoming less and less healthy because of increased weight, increased lipids, cholesterol, triglycerides, increased girth size around their stomach, indicating they're gaining more fat, and that makes people more at risk for both diabetes and for cardiovascular disease. So it's the consequences of the weight gain that we're most concerned about, and that the study did in fact show that there was a higher risk of the metabolic syndrome occurring in those women who gained the weight. Another study that was presented at the conference that was also looking at weight was the OPERA study. The OPERA study is one that has been going on for many years in the US. It has enrolled over 115,000 HIV positive persons. It's a clinical cohort, which means that it basically just follows people and sees what happens to them over the course of their treatment. It is going on in 65 cities, 19 states, and Puerto Rico in the US, and it has enrolled almost 8% of the total US persons with HIV population. So what they did in this study is they looked at just the individuals who were switching from a tenofovir-based regimen to a TAF-based regimen, really trying to isolate what the effect on weight was in terms of switching from tenofovir to TAF in those patients that had good virologic suppression. what you see here is that the patients who were switching were most commonly patients who were taking an integrase inhibitor like L-bictegravir cobicistat and switching off of that, or patients who were switching off of rilpivirine, or patients who were switching off either darunavir or atazanavir. So what they did is basically just try to hold one factor, only look at the effect on weight when they changed just one drug in a 3 or 4 drug regimen from tenofovir to TAF. And what we see in this study was that, in this clinical cohort, I should say, that the weight change that occurred with the single drug change, but maintaining all other antiretrovirals, actually was greeted with weight changes for everyone, all of them across the board. Integrase inhibitors, NNRTIs, and boosted PIs. But the weight gain was sort of limited. And as you can see in the table below, the change in weight was actually not too much different at the beginning of this study. But during the next 9 months after the switch, there was significant weight gains that were occurring, mostly in the patients who switched to an integrase, who were on an integrase inhibitor and switched to TAF, but also in patients who were on NNRTIs or boosted PIs and switched to TAF. So this is not just occurring with integrase inhibitors, it's occurring with NNRTIs and PIs too, although greatest with integrase inhibitors. After the 9 months after the switch from tenofovir to TAF, the weight gain seemed to kind of level out and became very similar among all 3 arms. So the other thing that they looked at was kind of breaking it down of just the patients who were already on an integrase inhibitor and switched from tenofovir to TAF. And what this figure in this table shows, again, same kind of weight gain occurring primarily in the first 9 months after the switch from tenofovir to TAF. And this time we get a look at different integrase inhibitors. What we see there is that the greatest amount of weight gain occurred in those patients who switched to TAF who were on L-bictegravir cobicistat in the form of Genvoya, exactly, but less so with dolutegravir and even least with raltegravir. This study also looked at those group of patients who switched 2 medications in their regimen, both tenofovir to TAF and also switching to an integrase inhibitor to see what kind of effect that switch of 2 medications might have. Again, where the biggest change in weight occurred was in the first 9 months after the double switch. And interestingly, this is the first time we really got some good look at a cohort with switching to bictegravir plus TAF. And we see that the greatest amount of weight in that 9 months, 4.47 kilograms. Remember, kilograms are equal to 2.2 pounds. So this is actually getting close to almost 10 pounds of weight in 9 months with bictegravir, followed by dolutegravir, and then lastly by L-bictegravir cobicistat or Genvoya. So I think this kind of gives us an idea that switch to TAF is in fact having an effect on weight. Just to kind of contrast that, we have a new NNRTI that's been on the market for about 1.5 years now called Doravirine, and it is being combined in a single tablet regimen with generic 3TC and generic tenofovir. So in the drive shift study, patients who were on boosted PIs, boosted L-bictegravir, or NNRTIs and had good suppression of their virus were either switched immediately to the Doravirine regimen. Doravirine is an NNRTI, considered to be a 2nd generation or next generation NNRTI, or they stayed on that regimen that they came in on and then switched later. And so the look at what effect weight changes were having after the switch to Doravirine, either an immediate switch in about 450 patients versus a later switch in about 200 patients, was that the weight was really not that dramatic, only 1.2 to 1.4 kilograms after more than 2 years of follow-up, some even as long as 3 years. Over 70% of the patients gained less than 5%, and only less than 10% had a weight gain greater than 10%. So really, what is being shown here is that the Doravirine regimen does not seem to be associated with weight gain. Why is that important? Because as we learn more about the use of especially TAF-based and integrase-containing regimens, the concern about whether or not the weight gain is reversible is going to be tested in several studies coming up very soon, in which those patients who have had significant weight gain are going to be switched to Doravirine, 3TC, and tenofovir to see if that weight gain is in fact reversible when switching to a medication that has not been associated with weight gain to date. Switching a little bit now to metabolic changes. As I said at the beginning of this section, all of our antiretroviral medications that contain integrase inhibitors, especially the dolutegravir and bictegravir ones, work really well. And it's hard to really just differentiate between them as to how well they work in terms of suppressing virus and keeping it suppressed, and actually how well tolerated they are. So metabolic changes are getting more and more important. The TANGO study, which is an ongoing trial, which took patients who were on a 3 or 4 drug TAF-based regimen, and most of them actually were on Genvoya, who were in this study, and then half of them were switched to a 2-drug regimen of dolutegravir plus 3-TC, also called Dovato, and half remained on their TAF-based regimen. And so the results of the study virologically at 1 year has shown that there's really no difference in those patients who switch to Dovato versus those who stay on their TAF-based regimen. Very few patients, actually only 1 patient had virologic failure, and that was in the TAF arm. But what is probably getting more important are the metabolic changes that can occur after the switch from a TAF-based regimen to Dovato. And so far, looking at some of these metabolic parameters, the one that really kind of jump out at us, number one, is that in the boosted subgroup, those patients who switched off of a boosted PI or off of Genvoya, a boosted integrase inhibitor, onto Dovato, showed that there was actually a decrease in mean fasting insulin. Insulin is the hormone that actually is secreted when we eat sugar in our diets. And when insulin gets higher and higher, it starts to really show that perhaps we are becoming what's called insulin resistant or diabetic. And what we see here is that the mean fasting insulin decreased in those patients who switched from a TAF-based regimen that were on a boosted medication by almost 12%, versus those who stayed on the TAF, which stayed about the same at 0.1, but it was statistically significantly different. And probably even more important here, one of the ways that we start to measure early evidence of diabetes occurring is by a study that we call the HOMA-IR, or the HOMA Insulin Resistance Study. And what this measures is how insulin resistant a patient is becoming. What we see there is that with the switch, the HOMA-IR went down by almost 10 points in the Dovato arm, and actually went up almost 5 points in the TAF-based arm. And I think that's something that's really important to really look at, is that we may start to be seeing the difference here now in terms of diabetes factors between patients who stay on TAF versus those who switch to a 2-drug arm like dolutegravir 3-TC. The lipid changes here were significantly different, as you can see there, for total cholesterol, LDL triglycerides, and the total cholesterol HDL ratio, because the p-values are all less than 0.5. But it was only seen for those patients who switched off of a boosted medication, meaning off of a boosted PI or off of Genvoya, a boosted integrase inhibitor, but not off a regimen that did not contain a boosted medication, as shown in the panel on the extreme right there. Weight gain. Interestingly, in this study, there was really no significant weight gain of coming off of TAF or maintaining TAF, as one might expect. 0.8 versus 0.76 kilograms over the 1 year period of time. It did differ how long someone had been on TAF to begin with. If they had been on TAF for a short period of time, the weight gain was greater, but really no different than those patients who switched to Dovato versus those who maintained on TAF. And finally, this study may be starting to show us something in terms of risk for diabetes, meaning if the HOMA-IR test comes out to be greater than 2, it is a pre-warning that person is starting to become diabetic or insulin resistant. And so what was seen here was that in the figure on the right, overall, the proportion of patients that were becoming diabetic was less in the dolutegravir 3-TC arm. It means that it favors that switch. And this was driven primarily by the patients switching off of a boosted TAF regimen that was also statistically significant, although not significant of those who were switched off an unboosted regimen. In terms of metabolic syndrome, at this point in time, there was really no difference for the effect of the switch to Dovato in terms of developing the metabolic syndrome, a harbinger of cardiovascular disease and diabetes. Switching now a little bit over to cardiovascular disease. two large cohorts, both the Kaiser Permanente cohort from Northern California, as well as the Partners HIV cohort from Boston associated with the Harvard hospitals there, looked at over 10,000 patients when they combined their two cohorts for a 20-year period to look at the evidence of cardiovascular disease, either coronary artery disease or strokes, heart attacks or strokes. They were followed for about 1.5 years. They calculated what's called the cardiovascular 5-year risk scores by what's called the ASCVD risk estimator, and also the classical, but oftentimes less precise Framingham score as well. The individuals that were in this cohort, as you can see there on the right, more from the Kaiser Permanente than in the HIV Partners in Boston, about the same age, in the mid-40s, primarily male, primarily white, but also fairly good representation, at least from the Partners for African American, and about somewhat better for Hispanic in California. The results here really showed that there was less viral load suppression in those patients in Boston. CD4 cells were high, smoking was pretty high as well, 44% from the patients in Boston, but low rates of diabetes, but pretty good rates of hypertension. The point from this study really is that the cardiovascular risk predictor scores, the ASCVD score, did not provide good fit for persons living with HIV. And what this tells us is that the scores that the American College of Cardiology and the American Heart Association have devised for trying to estimate what a person's risk for a heart attack is don't work well for persons who are HIV positive, and especially women. So what this is actually telling us, as you see there, in the green bars in the four figures is the predicted rate of cardiovascular disease. In the teal colored or kind of blue-green bars is the observed, what actually happened over this 10-year period of time. And as you can see for both HIV Partners and the Kaiser Permanente group, the observed was higher than the predicted in almost every situation, and for women, particularly higher than it was for men. So I think this is something that really underscores what this study had to tell us, and that was that we need an HIV-specific and a sex-specific risk score calculator to really be able to give people who are HIV positive, especially women, a better idea about their cardiovascular risk problems down the hall. I mean, down the road. There was some really big news about antiretroviral therapy and pregnancy that I want to share with you. Many of you have heard about the SAPAMO birth outcome surveillance study that's been going on in Botswana for many, many years now. We have heard two previous updates from this study. The first one in May of 2018, when an unplanned analysis of this birth cohort that was really looking at the evidence of birth defects, particularly what's called neural tube defects. Neural tube defects are ones that involve the brain and spinal cord, and oftentimes are fatal or when they occur or have severe mental retardation consequences. Excuse me. So what this study surprisingly showed at its first analysis in May of 2018 was that patients who were on dolutegravir actually had a higher than expected and significantly higher than patients who were not started on dolutegravir, and the women who were taking the medication when they conceived their pregnancy, when they got pregnant and were on the medication, dolutegravir or non-dolutegravir. So at the first analysis, it was a significant difference and really set off, I think, the alarm bells around the world that women who were able to get pregnant, but not on birth control, who wanted to get pregnant actively should not be taking, and who were HIV positive, should not be taking dolutegravir. A follow-up a year later in April of 2019 found that the neural tube defect prevalence had decreased from 0.94% down to 0.3%, a dramatic decrease, but was still significantly higher than the only 0.1% in the non-dolutegravir treated women. So what was presented at this conference was the third update, I should say, the second update after the initial 2018 one, now dated April 2020, that showed that the incidence of neural tube defects, prevalence of neural tube defects continued to drop down to 0.19. And this was actually within the same statistical ranges as those patients who got a non-dolutegravir containing regimen at the time of conception. So I think this has really now gone full circle to show that that initial increase in neural tube defects is not persisting. And as I think most guideline panels around the world are going to do, the WHO guidelines already changed, saying that women could be treated with dolutegravir if they were informed of the potential risk. Is that this further, I think, lends the safety value to say that that signal of neural tube defects occurring more commonly in HIV positive women who are on dolutegravir at conception is going away and is now no longer significantly different than those who don't take dolutegravir at conception, which of course is really great news. The thing that has really confounded this study all the way around is that folate, a vitamin that is commonly found in flour in many countries around the world, and is important that women take this during pregnancy in order to avoid the birth defects like neural tube defects, is not used in the foods in Botswana. And that is a very complicating factor, because we can't tell whether this is occurring because of the lack of folate or because of the effect of a medication. But this slide just kind of summarizes the fact that the initial analysis and the current analysis, the prevalence of neural tube defects has dropped from 0.94 to 0.19 and is really no longer significantly different in those patients who are not on dolutegravir. So moving on to HIV prevention, a few interesting things to start off with. For many of you, you might be interested to hear that the prevalence of PrEP use in women in the United States has actually improved, but is still showing some big holes. The CDC, of course, recommends PrEP for heterosexual women at risk for HIV infection, as defined there in terms of inconsistent or zero use of condoms, high number of sexual partners, STIs, or commercial sex work, or a partner with HIV. And so some of the national trends in PrEP prescriptions have been followed. And what is seen here is that over that 6-year period between 2012 and 2017, the overall PrEP use rates in women has dramatically increased from 8.5 per 100,000 up to 102. And this is seen in all age groups, particularly in the 25 to 45 age groups, has been seen primarily, however, in the Northeast, somewhat in the West and Midwest, but the poorest in the highest hit area of the United States in the South. And this slide really brings this to I think, a very stark sort of realization, is that with 56% of new infections in HIV that occurred in 2017, only less than 30%, however, of PrEP prescriptions were given for women in this part of the country. So a huge imbalance between the PrEP to need for PrEP ratio. I think it's really re-emphasizes the fact that the emphasis on women really is one that focuses on the South and Southeast, although not to forget, of course, the Northeast, Midwest, and West at the same time. But the biggest need for PrEP certainly remains in that red area of the slide. So what can PrEP do? How well do patients stay on PrEP? And if they do stay on PrEP, how well does it work? Again, we look at the Kaiser Permanente from Northern California, which had been following patients from 2012 to 2019. They were 95% male, as the population in Northern California is primarily male, half white. I'm sorry, 50% white, 21% Latinx, but only 7% African American. They linked PrEP or had a clinical encounter or referral for almost 13,000 patients during this 7-year period of time. There were over 10,000 PrEP prescriptions written. About 8,500 were initiated. And in terms of persistence, they measured this by how many refills the patient was getting and was staying within the less than 120 days since they last refilled it, is what they consider to be persistence. And that was over almost 6,300 patients. Overall, among that 7% of African Americans, they found that they were less likely to receive a PrEP prescription, less likely to initiate PrEP, and more likely to discontinue PrEP. Looking at the effect of PrEP persistence and its effect on preventing HIV, they were able to look at almost 13,000 person years of PrEP use, with a mean of about almost 2 years of PrEP use per person, which is actually pretty good. They noticed that of the over 2,500 that were not persistent on PrEP, a little over a third did in fact restart. Looking at the 5-year data, 5 years of data, they showed that the PrEP persistence started high, meaning these people staying on PrEP consistently at 73%. By 5 years, it was less, it was at 56%. But of course, we have to keep in mind that people are probably not going to stay on PrEP forever. PrEP, as we best can think of it, is used during seasons of risk. So the fact that the number decreased over time is not too surprising. The important thing that really came out of here was what they found was that there were no new HIV infections diagnosed in the 12,810 person years of patients who adhered to PrEP, really indicating from this real world data that PrEP works. What they showed interestingly here, and I'll show you the two big red boxes, is that those patients who were linked but didn't receive a prescription had a 1.4% rate of new HIV infections. Those who discontinued PrEP, a 1.5%, but if they were persistent on PrEP, it was tenfold greater, tenfold less at 0.14%. So again, I think really indicating from some real world data that PrEP does in fact work, but there's still demographic differences in terms of who gets it and who stays on it. The Discover trial, of course, was a trial you've heard about probably many times before. The study that was done in HIV negative, MSM, and transgender women who have sex with men and were at risk for HIV, higher risk for HIV infection. Patients were randomized to either Truvada or to Descovy. Large study, over 5,500 persons, primarily young, primarily white, and very few transgender women in this study. So this was something that I think was really a study that really demonstrated the similarity between the efficacy of Descovy to the efficacy of Truvada in MSM and transgender women. You'll note that there were no cisgender women enrolled in this study, and therefore this medication, when it was approved, Descovy that is, was not approved for cisgender women or women who have sex vaginally. The Discover trial has been criticized by the fact that the demographics showed that it was primarily white men, 84%, primarily MSM, very few Black or Hispanic, and also very few transgender women. So whether or not they actually captured the persons at risk for HIV infection in the US and Europe was always one that was questionable. So the way they tried to look at this was to see how many STIs were occurring. And they did in fact find that the STI prevalence was in fact over the 2 years of the study high, shown in the green and teal bars there. They did show that it was for those patients who did have a new diagnosis of gonorrhea, chlamydia, or syphilis, that there was a higher rate of those STIs occurring in those persons who did in fact acquire HIV versus those who did not. Overall, being in the study actually decreased the rate of gonorrhea or chlamydia by almost 10%, and the rate of rectal gonorrhea or chlamydia by almost 6%, which is great. But again, as that graph to the right shows, persons who acquired HIV in this study versus those who did not had a higher historic rate, meaning before they came into the study, of rectal STIs, and a higher incidence rate, new STIs during the trial as well. Again, something that doesn't surprise us so much, but is consistent with what we know about the transmission of HIV being linked to sexually transmitted infections. Now, if there's one thing I leave you with more than anything else is the results of this study, HPTN 083, the HIV Prevention Trials Network study that really looked at a new way of delivering PrEP with long-acting injectable cabotegravir. Cabotegravir, as the name sort of implies, is an integrase inhibitor very closely related to dolutegravir, and it has been studied as an intramuscular injection given on a once every 2 month basis. HPTN 083 compared this injectable long-acting medication to daily oral Truvada for PrEP in men who have sex with men and transgender women. A big shout out has to go to the study organizers and all the investigators who enrolled this study, because it was in fact an international study in the US, North America, South America, Europe, Africa, in Southeast Asia, but it did in fact endeavor to enroll primarily persons under the age of 30, and that was done. Over half the people were actually under 30. And furthermore, 50% of the persons enrolled in the United States identified as African American women, transgender women, I should say, or African American MSM. This study has kind of gone in 3 parts. First of all, persons started on an oral medication. Let me back up and say this was in fact a double-blind, double dummy clinical trial design. In step 1, all persons started on an oral medication. Those who were randomized to the cabotegravir arm started on oral cabotegravir for the first 5 weeks. Those who were randomized to receive Truvada got oral Truvada. Each of them also got an identical looking pill that was a placebo for the other arm of the study. After 5 weeks, with good tolerability, what they then did is started giving injections to both groups and continuing the pill. However, the pill in the cabotegravir arm became a placebo, and the injections they started receiving in step 2 was genuine cabotegravir delivered every 8 weeks, about every 2 months. In the Truvada arm, the Truvada pill stayed the same, and the person started getting a placebo injection. And this has been going on now for a long period of time. So in this study, there was an interim analysis that was announced on May 14th of this year, when 25% of the expected endpoints were accrued or had occurred, meaning that 25% of the predicted number of new HIV infections had occurred. This was done as a way to try to maintain safety in the study, to make sure that the arms of the study, each arm of the study was not causing more toxicity than the other, or that expected, but also to see whether or not the efficacy between the 2 arms was how it was doing. So at the point in which 25% of the expected new HIV positivity cases had happened, the Data Safety Monitoring Board recommended the study be unblinded, because of the fact that what was seen in this study, as shown on this slide, was that the injectable cabotegravir arm was associated with many fewer new HIV infections than those persons receiving oral Truvada. And because this was a placebo-controlled trial, it really made it obvious that the injectable cabotegravir was working much better at preventing HIV infection by about a 66% decrease in new cases of HIV. When we look at those 15 new infections that occurred in the long-acting injectable cabotegravir arm, this is broken down into kind of how they each occurred. The A1 and A2s there at the top of the slide occurred as infection before anyone got any medication, which means that they were already infected before they came into the study and were just not caught as part of the screening. So they really don't count as new infections because they were already infected. When we look at the next category of how they occurred in the B numbers there, B1 through B5, it is noticed that there was infection that occurred after a prolonged break or hiatus from the cabotegravir, which oftentimes was in several weeks up to almost over 2 years. The next thing that occurred, of course, was infection during the oral lead-in phase, before any injections had ever even been given. And so those are all things that we can kind of say are not true failures of the injectable cabotegravir because they occurred too early or after the cabotegravir had been stopped for a long period of time and would not have been expected to have an effect. But the last 5 there, the D1 through D5 new infections, occurred while the people were receiving on-time continuous cabotegravir injections. And it's these 5 out of 15 new infections that are really going to become the focus of how cabotegravir works. Of course, I think it's important to note that there were 36 total infections in the Truvada arm, which really makes a big difference. And when we break this down even further, only 3 of those Truvada infections occurred during the administration of study drug, before the administration of study drug. So very much fewer, less opportunity for those to really not be associated with true failure. But the measurement of drug levels and the resistance of those patients who did have new HIV infections despite their continuous on-time cabotegravir injections will become a very important next report of this study to really see what's going on. The adherence to Truvada was measured by dried blood spot measurement of the amount of a Truvada metabolic product called tenofovir diphosphate inside of cells from the patient's blood. And what they showed here was that the amount of Truvada in the blood actually was very good in terms of adherence. Over 75% of patients overall had good adherence to the Truvada, meaning that they had levels that should in fact be fully protective against new HIV infection. It did wane a bit over time from when it started at week 4, when it was better than 75%, but even out to over a year, it was still looking very, very good at around 70%. So one of the things that, of course, would be the first reason to explain why Truvada was not working as well is because patients weren't taking it. But these adherence data seem to contradict that, because the study investigators anticipated they would only get about 60 to 65% adherence, and here overall it was better than that at 75%. So the adverse events associated with and weight gain showed that there was really not a big difference in terms of adverse event differences, except for the fact that 47 patients in the cabotegravir arm permanently discontinued the injections because of injection-related adverse events, which again is not too surprising that this might happen. 47 out of 2,200 is almost 2,300 is not really a big surprise. There was greater creatinine clearance or renal function problems with the tenofovir patients. Other things there probably have not been fully explained yet. Why there was more increase in blood glucose, blood sugar with cabotegravir is yet to be defined. And it is thought that the pyrexia, which means fever, occurred more commonly in the cabotegravir patients as part of the injection site reaction, the inflammation that occurred there. Overall, the weight changes in the study were very, very interesting. For the first 40 weeks, it was noted that those patients who got injectable cabotegravir, they gained about 1.5 kilograms, which breaks out to be about 4 pounds, a little less than 4 pounds. Whereas in the Truvada arm, on average, patients lost a kilogram, or about 1 pound. Then in the next year of the study after that, the weight gain in both arms of the study was almost exactly the same, about a little over 1 kilogram. So overall, there was a greater amount of weight gain in the cabotegravir arm, 1.3 kilos versus 0.3 kilos. But note that that initial weight with the Truvada arm was in fact decreased over the first 40 weeks. So there was actually weight lost to begin with and then regained later on. It was noted that when the study was broken down by age groups, greater than 30, less than 30, transgender women, and in fact 12% of the persons in this study were in fact identified as transgender women, Black African or Black African American or non-Black non-African American. The differences in terms of how well the medications worked, even regional, that what study was done, did not differ. It worked in all key populations studied in this trial. The adherence, however, was different for tenofovir. Overall, as I mentioned, it was about 70%, greater in Asia and the US, less so in Latin America, greater in non-Black versus Black patients in the US. Really no difference in terms of age groups, but in terms of gender identity, sexual orientation, better in MSM than in transgender women. I'm going to move on now because I know we're getting close to the hour time and look at a couple of investigational HIV treatments in the pipeline. The first one I'll talk about is a medication now known as islatravir, or formerly called MK-8591. This is a new class of medications called an NRTTI, a nucleoside reverse transcriptase translocation inhibitor, NRTTI. And it is being combined in a 2-drug regimen with Doravirine. The study called the P011 or P11 study started off as a 3-drug study using 3 different doses of islatravir at 0.25, 0.75, and 2.25 milligrams, put together with Doravirine. as well as 3TC. After 24 weeks in good viral suppression in these antiretroviral naive patients, the 3TC was dropped out if the patients were in fact undetectable, and the patients were continued on just 2 drugs, islatravir plus doravirine. At 1 year of follow-up, the viral load suppression in the 2 lower doses of islatravir are looking very good, right around 90%, and similar to what has been seen before with integrase-based regimens. The control arm there of doravirine plus tenofovir 3TC is performing about as well as any efavirenz arm has performed before at around 84%. You notice that there are more patients in the high dose arm of islatravir, the 2.25 milligram arm, who had virologic failure and fewer virologic successes. So we look at kind of where this came from. So looking at protocol-defined virologic failure after 1 year of study, it was interesting to know that only 1 patient in the entire study had non-response, which means that their viral load never went down below 50. They never became undetectable. However, when you look at the patients who were above 50, there were 2 in the lowest dose, 2 in the middle dose, 0 in the high dose, but only 1 in the doravirine 3TC tenofovir arm. But interestingly, this study used a very, very strict definition of protocol-defined virologic failure, in that no patient had a viral load over 200. So there was not the opportunity to do any kind of genotyping in those patients who had virologic failure, because none actually ever came over 200, which is usually the cutoff level for virologic failure in most modern integrase inhibitor studies. So if we were to analyze this trial like integrase inhibitor studies have been analyzed recently, there would be 0 patients who actually had virologic failure. The reason for patients who had greater than 50 but not classified as protocol-defined virologic failure shown here, 0 in the low and middle dose, but 3 patients in the high dose, and this really accounts for why that difference occurred. 2 were lost to follow-up, 1 withdrawal, and 1 protocol violation in the doravirine control arm. So adverse events across the board were occurring in not too much different in terms of maybe a little higher for drug-related events, 13% for the high dose, 10 for the middle dose, and 0 for the low dose there. But in terms of moderate or severe, again, not a big dose-related sort of problem, meaning that they were not worse as the dose of islatravir increased, and were in fact less than those moderate or severe adverse events were seen in the doravirine arm. Most of the adverse events were either diarrhea, headache, and they were all mild, or nausea, I should say. They were mild, transient, and were not deemed to be related to study drug. Metabolic changes and weight gain, of course, is very important. The important thing here is that the effect on glucose was really not different across the board. They all overlap. The total cholesterol HDL ratio all went down for both the islatravir and the doravirine arms in the study. And the weight gain here was, in fact, really no difference in terms of those proportions of those patients had a 5% gain from weight gain from baseline. So very small numbers had much of a weight gain at all, really no difference between the doses of islatravir or those on doravirine. So the other medication I want to talk about used to be called GS6207. This is an HIV-1 capsid protein inhibitor. It now has a name instead of just a number called lenacapavir, and it has been formulated into both an oral and a subcutaneous injectable medication. In these 30 HIV negative individuals, a single dose of lenacapavir of 900 milligrams was injected, either 300 milligrams or 900 milligrams. The 900 milligrams was delivered as 3 1 ml subcutaneous injections, or 2 1.5 ml subcutaneous injections. And what we can see here in the green and red line there was that the level of the resulting lenacapavir in the plasma of the patients who received it was higher than that is thought to be able to suppress most HIV viruses for as long as 6 months, which I think really points out a very important effect of this long-acting subcutaneously injected medication. The challenge here, of course, is going to be seeing what medication this could be paired with, because we do not know whether, we do know this medication can lower HIV viral load very well over a 10-day period of time, but it has not been studied for longer that period of time as reported yet. And usually giving one medication by itself for HIV infection has never worked. So trying to find a partner for this drug is going to be something that's going to happen. HIV cure, there were a couple of good studies. One, of course, was the report of a remission, maybe a cure of chronic HIV infection without doing a bone marrow transplant. This was a 35-year-old Brazilian Caucasian male who was one of 5 studies enrolled in a trial called the SPARK trial in 2016. His viral load, it was undetectable at baseline, and he was already on a tripla. To that, they added dolutegravir and maraviroc, and also a medication, or a vitamin, I should say, called nicotinamide, dosed at 500 milligrams twice a day. Nicotinamide is thought to be what's called a latency reversal medication, which causes latent HIV that's hidden inside of cells and is not metabolic, is not replicationally active, to become more active and is exposed then to the immune system. So all 5 people were on this medication, these 3 new medications for 1 year. They then went off those new medications and went back onto their, just stayed on their previous medication, and then they went on to what's called a analytical treatment interruption. It started for him in March of 2019. At the time of the study, his viral load has remained undetectable for almost 65 weeks, over a year. He had a decrease also in his HIV antibody, which has been seen in other patients who were cured of HIV infection, but no change in the Western blot, indicating the viral antibodies were in fact still there. And the question here, is this person really cured or not? 65 weeks is probably not long enough time to really say this is a cure, but it was worth reporting because this was the first time that an all-oral regimen had been associated with what might be suppression of HIV on a long-term basis. So we'll have to wait to see whether or not what this turns out to be. Another medication called vistazolamide, which is a biological medication, which in fact upregulates many parts of the immune system, was given at many different doses, between 2 up to 8 milligrams per day, versus a placebo. I'm sorry, not per day, every other week. And then analytic treatment interruption was started in persons who were already suppressed on medication. These patients were in fact considered to be what's called HIV controllers, meaning that in the 2 years before they started antiretroviral therapy, the viral load could never be greater than 5,000. Once they started antiretroviral therapy, they've been undetectable for at least 6 months, and CD4 cell counts over 500. The good news about this study, and I'll just summarize it quickly, is that in all of these measurements of looking at different kinds of immune reactions, the addition of the vistazolamide markedly increased the amount of these different inflammatory cytokines. Immune responses actually were very good. More activated T cells of all sorts, both memory, effector cells were looking very good. So what this is really telling us is that this seems to be a medication that can in fact activate the immune system in persons who are HIV positive and suppressed on antiretroviral medication already. More to be seen how this could be used in terms of a cure strategy for the future. And the last thing I'll just do is quickly go through some COVID-19 studies. You probably have heard of some of these. One from 5 different emergency departments in New York City that looked at 93 patients, primarily males, 58 years old, 41% African American, 31% Latinx, had been HIV positive for 20 years on average. CD4 cell count median was 320. 84% were undetectable. And important to say that 70% weren't, or 96% were receiving medication, antiretroviral medication, at the time of having COVID-19. 70 were in fact were on tenofovir or TAF, which just kind of speaks against the fact of those medications being protective from COVID-19, and 13% were on a PI. Again, showing that it probably didn't protect either. The thing that was first of all noticed was that the CD4 cell count seemed to decrease from their pre-COVID versus when they got COVID pretty dramatically. Both the CD4 cell count dropping from 464 to 188, as well as the CD4 percentage dropping from 28 to 23, and the absolute lymphocyte count. Again, none of this is probably very surprising because of the fact that with inflammatory reactions, oftentimes viral infections cause some of these cell populations to decrease initially. The inflammatory cytokines, which are well known to cause most of the problems with COVID-19, like CRP, fibrinogen, D-dimer, interleukin-6, TNF-alpha, were elevated in the majority of patients whenever they were tested. So what about those patients who died versus those who did not die? What were the discriminators? 26% in fact died, 74% recovered of these 93 patients. What was found was that those who died had lower absolute lymphocyte counts, the kind of cells that CD4 cells are, both when they were treated, their lowest level, as well as when they first came to the hospital, versus those who recovered. Those patients who had high CRP, C-reactive protein, interleukin-6, and high IL-8, interleukin-8, were those who died versus those who had other inflammatory cytokines like fibrinogen was really not different. So I think this is something that, again, gives us the idea that HIV positive patients are reacting exactly the same as HIV negative patients. One study from the Bronx actually demonstrated that in those patients, there may have been a higher rate of bad outcomes. Although when we look at the 100 patients with HIV versus 4,500 without HIV, only one almost significant p-value, not quite significant because it came out to be 0.051, greater than 0.05. It was in terms of the number of patients that were intubated, had to be put on a ventilator, 21 versus 14%. Death was no different. Length of stay in the hospital was no different. The time to intubation was not significant, nor the time to death or time to discharge if they survived. Interesting, looking at the HIV positive patients, those who were virologically suppressed or unsuppressed. Surprisingly, those that were unsuppressed had less intubation, less death in the hospital, as you might not want to expect. But I think the thing that they found here was the CD4 cell count prior to admission was associated with an increased hazard, increased rate, or risk of being intubated, putting on a ventilator. So this may be telling us something about what the purpose of the CD4 cell count predictively can be. The last two things I'll talk about is about COVID and PrEP. A survey of both PrEP users as well as PrEP providers was discussed. It was done by the Academy of HIV Medicine database. What they found was that during the shelter-in-place orders, PrEP users reported that a third of them, of 394, stopped taking PrEP, primarily because they didn't feel like they needed it or they couldn't get it. But interestingly, there was no change or an increase in risk behavior in 10 to 15%. In terms of PrEP providers, they were saying that they were providing fewer, both new as well as refill prescriptions, that the encounters were for possible reported STI were decreased by 81%, which is not a good thing that's happening. So certainly seeing that COVID is affecting both the starting and the continuation of PrEP, while risk behaviors may not be going down. The Fenway Community Health Center in Boston reported things very similarly. But the bottom line here is that new PrEP starts between January and April of this year dropped by 72%. The number of patients with an active PrEP prescription dropped by almost 20%, and tests for HIV, gonorrhea were dropping also dramatically. So I think this is really showing how COVID-19 is impacting HIV care in two different centers or one center and a national survey in the US. So I'll stop there and ask for any questions that you guys might have and say thank you very much for your attention.
Thank you, David. That was really good and a lot of information, and it's amazing to see how HIV research is paying off. You know, seeing all these also new combination of treatments and the long actings. I have just one question, and then we can go to the chat. I was wondering, all these PRT related weight gain. One of the concerns that I have, and I guess that you show that they're going to be studying other RTIs that could, you're going to look if they can reverse the weight gain. But, for the population of people that are aging with 50, 50 plus aging and that are on HIV treatments, what are the things that we can tell them they can do in order to prevent weight gains or to control weight gains, and knowing that may be related to the medications they're taking, which they probably will not want to stop.
Yeah.
How you as a physician will work with them to prevent the weight gain?
Yeah. That's a great question, Moises. I think the one thing that we have to realize is that it is normal for adults, especially those greater than 50 years old, to gain somewhere between 1 to 1.5 kilograms of weight, meaning 2 to 3 to 5 pounds every year as we continue to age. That's normal sort of a weight increase, unless we're doing something about it. So I think the thing that, first of all, I would say is for persons who are HIV positive on medications, especially those who may be on integrase inhibitors like dolutegravir and bictegravir, with which weight gain has already been seen, and those individuals who are on TAF. The thing that's a bit concerning here, of course, is that some of our best, most potent and well-tolerated medications are the ones that seem to be associated with weight gain initially right now the most. So many people are on probably those integrase inhibitors, and many people are on TAF. I think the thing to really notice is to monitor one's weight very carefully. Sometimes when people go in to see their practitioner, their clinic, they may not get weighed because somehow they consider it to be a problem, or there's not enough time, or whatever. And I think what I would do, first of all, is make sure they are weighing you every single time you're seeing them in the clinic. And additionally, get your own reliable scale at home and monitor your weight. Because if you're not monitoring your weight, you're really not able to tell whether or not it's changing. The other thing, of course, is to realize that it's normal to gain weight as you age, unless you're doing something about it, meaning unless you're decreasing the amount of food you're eating and increasing the amount of activity that you're doing, or maintaining the activity. Weight will continue to come on our bodies unless we do something about it. It's the natural history of aging to gain weight, which will continue unless we really stop and, first of all, recognize it by doing weights frequently, probably at least once a week to once every 2 weeks at home. And every time you see your clinic or doctor, have them get your weight and write it down, because that is a great way to be able to really see whether things have changed with when your medications were started, when they were changed, whatever kind of factors were in there. Because there are probably, we don't know for sure whether the weight that is associated with integrase inhibitors or TAF is reversible. No one has shown that yet. It might be, if it is the kind of weight that we gain normally, especially fat weight, like for what was seen in the advanced study, it should be reversible if the medication is changed. So that is something that I think we have to keep ourselves open to, is perhaps changing. One of the things that is looking like it might be an alternative are some of the emerging 2-drug regimens that do not contain a tenofovir containing product, meaning tenofovir or TAF. Some of them do contain dolutegravir. There's 2 of the ones that are being studied now and are now approved, dolutegravir 3TC or dolutegravir ropivirine. But there are ways that 2-drug regimens could be put together. For example, like islatravir and Doravirine is coming down the pike as a new 2-drug regimen as well, that so far has not been associated with any weight gain. So again, I think it's just, number one, be aware what your weight is, monitor it, write it down, and see what's happening.
Yeah. Yeah, I think it's very important to not underestimate, the future consequences that we may face because of the weight gains, and those of us that, I mean, in terms of how this could affect comorbidities and cardiovascular disease and diabetes. Also was interesting to see the same in terms of gender and how these affect the weight in women. So the conversation about weight gain, it should happen with this population is aging, but it made me think that also for those that are HIV positive in their 20s, 30s, the message that, keep a healthy diet, do exercise, don't wait until further along, to deal with maintaining a steady normal weight. So thank you for that. I'm going to see how many questions we have at the chat, and maybe we can take one or two quick questions. Chip?
Yeah, first question we had, and David, this is actually going back to the very first study that you mentioned. And the question is, for those not reaching undetectable at week 24, what was the racial breakdown? And if any follow-up past 24 weeks, did they reach undetectable?
This is the acute HIV infection treatment study.
Yes, that's correct.
Right, the one from San Francisco. The racial breakdown was in fact in the slide there, I know, in which they were primarily white and Latinx, with fewer African American, I know, but I don't know if they did a breakdown of what happened on that 24 weeks. I mean, they reported that everyone had gone at least 24 weeks in the poster that was presented, but I don't know whether they actually did another analysis of what the racial breakdown was at that next time point. They just did it what was per reported, what was it done at baseline.
Okay.
Okay. One other question. Often clinical trials leave people of transgender experience behind, especially trans men. Are there any highlights you want to share about clinical approaches towards this population, or could you explain the absence of people with trans experience?
Yeah, I agree way around. It has been, I think, a real challenge on both sides, both in the trans community, but also in the research community, to best understand how transgender persons can participate importantly in clinical trials. I'll just say that, the one bit of good news that did come out of this conference was that the HPTN 083 study, the prevention study with Truvada versus intramuscular cabotegravir, did enroll 12% transgender women out of the 4,500 persons that were enrolled, which is a big difference than the 2% that were enrolled in the Discover prophylaxis study. So the HPTN 083 investigators made it a point to enroll both persons of color less than the age of 30, in this case MSM and transgender women, and specifically transgender women. So, what that trial proved was that it can be done. It can be done. If you get the right investigators, get the right sites, and set up ways to make it attractive for persons of color, persons who are younger, transgender population of individuals to come into a trial, it can happen. Oftentimes what the discussion has been around is that we open up our treatment site or trial site and no transgender people show up. And, that's, I think, just become a lame excuse at this point, because in order to get persons who we need to understand better about their use of HIV medications, we have to reach out to those communities, build bonds, build trust, and invite them to become a part of this whole research process. I agree with you. It's been tough. With speaking about transgender men, what we found when I was at Whitman Walker is that although we had over 800 transgender men in our clinic, less than only let's say around 70% had never been tested for HIV.
Wow.
70% had never had an HIV test in their medical record. And I think that's one of the problems that has occurred oftentimes with transgender men, is that while there have been many, many reports about elevated risk and levels of HIV positivity among transgender women, especially those of color, there's been very little reports about HIV in transgender men. We just couldn't find much in the published literature, and I was shocked to see that our HIV-based clinic had missed that many transgender men.
Chief, do we have more questions? It's 2:31 already.
We do not. No.
Okay. So thank you, David, so for this presentation. I think it has been very informative. And if I have, or we get people with further questions, then I will forward them if that's okay. Okay.
That'd be great.
Well, thank you so much, and I'll talk to you soon.
All right. Thank you.